This conference will now be recorded.
Do you hear me well?
Hello,
My voice
it's not clear, doctor.
not clear. My voice now clear?
Yes, now clear, yeah.
Okay. Hello all my colleagues. Today, inshallah, we'll start our third session. It will be about the antenatal and the maternal medicine module. In fact, there are many cases or many sessions may appear in the antenatal and the maternal medicine module, and it is wide module. So if you left yourself to study all the cases in the maternal medicine, you will not finish. So try to be focused on the most important cases and the cases which has a guideline and the cases which appear before in the exam, not to waste your time. And except and although all of this is still you may face a new case or a new session in your exam. I wanted to close the camera. Okay, my screen is appear now. My screen is clear now.
Yes.
Okay, let's start with our session, not to waste our time. So, who wanted to start our first case today?
I will do.
Okay, Doctora, can you
Anshuja.
pronounce your name, please? Anshuga?
Anshuja.
Anshuja.
Yeah. You can call me Anshu. It's fine.
Okay.
It's a little difficult to do.
Dr. Anshu, you have now 2 minutes to start to read the note of your case. Imagine yourself in front of the cubicle, and this is the first case you will start by which in the exam. This is the case note. So I will start for you 2 minutes.
Yes.
Start, please.
Should I start the discussion?
No, start to read the note. You have now 2 minutes to read the note.
Okay. Is there any other sheet?
Yes, after finishing that, I will show you the ultrasound of the patient.
Okay.
Okay. You wanted the previous screen?
No, it is clear.
Clear, okay.
बंद कर दो।
मम्मा ने गर्म पानी मांगा।
How many weeks? 32 weeks.
Okay, start now.
Okay. Hello. I'm Anshuja, the doctor in the clinic today. May I confirm your name and age, please?
Yes, hello, doctor. My name is Lambert John, and I am 36 years old.
And how would you want me to call you?
Call me Lambert.
Okay. Lambert, can I get the first name? So Lambert, you are 32 weeks into your pregnancy, and an ultrasound has been done for you, and you've come here regarding the same. Am I clear? Is it? And you've come regarding the same. Am I right, Lambert?
Yes, doctor. Yes, I follow my community midwife, and
Mm-hmm.
she told me that my baby is small. I don't know why, and she requested from me to do an ultrasound scan, and I am here
Mm-hmm.
today to know the result of the scan. So, can you assure me about my baby, please, doctor?
All your concerns are very well taken, Lambert. Lambert, is it okay if I ask you a few questions and then I can go on to discussing your ultrasound, and then together we can plan the best management for you? Is
Mhm.
it okay, Lambert?
Okay, okay, doctor. Okay.
Okay. Yeah. Thank you, Lambert. So, Lambert, can you tell me more about this current pregnancy?
Yes, this is my first pregnancy, and I am now 34 weeks, and everything is doing well. I did my routine tests in the start of the pregnancy, and all were normal. And I did my Down syndrome screen, and it was normal. Even my early scan was normal, and the an anomaly scan done at 20 weeks also was normal. I don't know why the midwife tell me that my baby is small.
Mm-hmm. And have you been regularly following up for your antenatal visits with your midwife till
Yes,
now?
I am follow my midwife regularly.
Mm-hmm. Okay. And have you been pregnant before, Lambert?
No, this is my first pregnancy.
Okay. And are you up to date with your smears?
Yes.
And are you following with your GP for any kind of medical problems like diabetes or hypertension?
No, no.
Are you taking any kind of medications on regular basis, Lambert?
No, except some vitamins only for pregnancy.
Okay. And have you had any surgeries in the past?
No at all.
Okay. And is there any family history of concern you want to tell me, Lambert?
No, no at all.
And are you allergic to any drugs, metals, or foods, Lambert?
No, no.
Mm-hmm. And Lambert, it's a part of my duty, to ask you a few questions which you may find intrusive. Is it okay? Is it okay if I ask you a few?
Okay, doctor. Feel free.
Yeah, thank you. Do you smoke, Lambert?
Yes.
Mm, and how much?
10 cigarettes per day.
And have you ever thought of quitting smoking, Lambert?
Yes, I tried many times, especially after my pregnancy, but I failed.
Mm-hmm. Lambert, let me reassure you that we have the NHS Stop Smoking services, and once you go on to decreasing your cigarette intake a day and then completely stopping it, will give you immediate health benefits to you and your baby. Lambert. So if you can, if you want, I can put you in contact with them, and we can arrange some group activity for you regarding the same. Am I clear, Lambert?
Yes, doctor, you are clear. Okay.
Okay. And do you take alcohol, Lambert?
No, at all.
And do you take any kind of recreational drugs?
No.
Are you well supported at home?
Yes, my partner is very supportive.
And what do you do for your living, Lambert?
I'm a teacher.
Okay. And in the recent past, have you ever felt low down or depressed, or any you do not enjoy any kind of activities that you did previously?
No, no, not at all. I am happy because I am pregnant.
Okay. Thank you for all the information, Lambert. So, Lambert, this is your. Let me explain you the ultrasound. I have cross-checked your NHS number and your name and your date of birth, and this is the ultrasound which has been done for you. And after doing an ultrasound, we have plotted your baby's your baby's weight and the head circumference and the diameter of your baby's tummy on these gestational charts, Lambert. This what this shows is that if we take the birth weight, the baby's weight right now, and according to the weeks of pregnancy, this is falling onto the fifth centile. If I explain you fifth centile, it's like the baby is weighing pretty less what it should have been for the weeks of pregnancy you are. Am I clear, Lambert?
Yes, you are clear, doctor. So what does it mean for my baby?
This means that that your baby is though your baby is doing pretty well, the blood flow to your baby from the afterbirth is currently fine, and water around the baby is fine, but then your baby is definitely less in weight and the growth parameters it should have been for your baby if it had been a totally normal pregnancy. So this may mean that you will require booking into a consultant-led clinic from now onwards. This may mean a few more scans for you at regular intervals, maybe every 1 to 2 weeks, to see how the baby is growing, and whether any kind of whether any kind of problems the baby is facing inside the womb. And this may mean a little more monitoring for you and your baby. Am I clear, Lambert?
Yes, doctor, you are clear. So what may be the cause of that, doctor? Why? Why my baby is small?
Lambert, sometimes in as high as 50% of the patients, we may not find any cause for this, for the baby being so low birth weight. But I'm really sorry to say that in your case, maybe because you smoke heavily around, as you told me that it's around 18 cigarettes a day. That could be one of the reasons that the baby is not being growing well
Oh
inside
my
the
God.
womb.
So I hurt my baby. Oh my God. I will
Don't
not forgive myself at all.
Don't feel depressed, Lambert. From now onwards, if we go and we are there to help you and support you. If you try to quit on smoking from this point of time onwards, maybe the baby can still grow inside the womb and may have a catch-up growth. These babies usually, once they are out and they're on their own, they usually fairly do well outside when they are delivered. But yes, if we um, uh, so am I clear, Lambert?
Yes, doctor, you are clear. So what we can do now, doctor?
So, Bill, as I told you that we'll book you into a consultant-led clinic. You may require a little more scans. We may require giving you a shot of steroid injections, as and when it will be given, will be told to you. And then if the baby will monitor you more frequently and do more scans for you in any time we find that the baby is not getting a good blood supply through the afterbirth, and the baby is not growing, or the body or the fluid around the baby in the womb is getting down, we may plan to have an early delivery for you. And this may mean kick starting your labor by giving you artificial pains, or if we find that the baby is actually distressed in the womb, this may mean a right away cesarean section also for you. Whatever will be decided will be discussed with you by your healthcare worker, and in case we decide to have a cesarean section for you before 39 weeks, we may need to give you a shot of steroid injections, which will be given in 2 doses at least 24 hours apart. And the baby may mean going to the nursery. The baby doctors will check the baby, and the baby may require going to the special baby unit also. Am I clear so far, Lambert?
Yes, doctor, you are clear. Yes.
Okay. Lambert, this is the information leaflet regarding the same, and these are the various support groups, and this is the hospital contact number. So please feel free to call us anytime, and in case you have any further questions, and if you wish so, I'll put you in touch with our NHS Stop Smoking services. Thank you, Lambert.
Okay. Thank you. Thank you. Thank you, Dr. Anjo. You still have 11 seconds, but good thing that you managed to finish before time.
Actually,
in fact, it is
I have forgot to ask a few questions in the current pregnancy. How are the baby moving? Is it a planned pregnancy?
yes,
And is the baby kicking
yes,
well? Is it a boy or a girl? I forgot to ask those questions.
yes, yes. No problem at all. It will be done during your practice and the repetition. Repeat the case more than one time. We'll fix the information, and you will collect the information that you missed in the first time. So it is the aim, and it's the goal of our practice to know what is the missing point to focus on. So thank you. Regarding to the feedback, this is one of the most difficult case, in fact, because it had curve, and it has a percentage, and it's difficult to explain the percentage for in the lay language for the mother. But you did well in communication with the patient. Regarding to the information gathering, you collected the information very well in systematic way. You ask about her pregnancy, and the scan and the test done in this pregnancy, and also the previous pregnancy. You forget to ask about the baby movement and whether she has any complaint right now. Regarding to the gynecological history, you ask about the cervical smear. It's one of the safety points, because this patient is 36 years old. So any patient more than 25, you have to ask about the cervical smear. You ask about medical and surgical history and family history. Psychological history didn't miss. It is very good. You ask about the social habits like smoking and recreation drug, because cocaine is one of the risk factor, and also smoking for the gestational age. And regarding to the information gathering, you finish all the item, but you forget one important question to ask at the end. Do you want to add anything, any other information you wanted to tell me? Because by this you will be safe. If the role player forget, or you forget to ask about anything, the role player will prompt it for you, so you will be safe by this. The role player wanted to tell you that she do go to the gym, and she do heavily exercise, and her weight is very important for her. So doing heavily exercise also one of the risk factor, and you have to explore and you have to ask in the exam about this question. So by asking at the end of taking the history, do you want to add anything, any other information you wanted to tell me? By this question, you are safe, because the role player want you to pass, and she will help you. And if you forget to ask about anything, she will prompt to tell you. The
Okay.
second thing you forget in the information gathering, and as we said in our first session, examination is part of the information gathering. So you have to examine this patient. I wanted to examine you in the presence of chaperone if you don't mind. In the presence of chaperone, and if you don't mind, don't forget to take consent. I wanted to test to check your pulse, blood pressure, temperature to be sure that you are in the best possible shape, and assess the fundal level. It is the height between the pubic bone and the top of your womb, and this to assess the growth of your baby. Okay, this is to confirm the examination done by the midwife. After that, you come to explain the result of the scan. You explain the result very well, but you forget only one point of safety. Safety point is very important to confirm the name of the patient again. We said that in our first session, when you come to explain the result of investigation or the result of scan to any patient, please confirm the name and the date of birth again. It will be right here
No,
or here the name. What?
I confirmed that I have checked the NHS ID and your name and your date of birth on the ultrasound. I told that.
You told that at the beginning of explaining the result?
Yeah.
Okay, very good. Okay, maybe I didn't hear that. Okay, so you have to confirm the name and date of birth before explaining the result of any test or any scan. And you explain the result very well, and you go to the management plan very well. You didn't put blame on the patient when she said I'm so oh my god, I hurt my baby. You did this in good way. You wasn't judgmental in your discussion. You can also tell her, Lambert, it isn't because anything you did or anything you didn't do. Don't put blame on yourself. Sometimes it can happen without any cause. But smoking and doing heavy exercise may be one of these causes. Like this, and you did it well. So coming to the model answer of this patient, not to waste our time, you greet the patient and introduce yourself well. And as we said, the first impression always lasts when you enter into the exam and you ask in a systematic way and in confidence. So you will give a good impression about you for the examiner. You check the purpose of the meeting and you put agenda for your discussion today. Then you take the obstetric history and the gynecological history and the social history. You ask about the drug, the social habit like smoking and the recreational drug. She was smoking and go to gym 3 times per week. You ask about the social history and the support at home. You ask about the psychological history by the two holy question and the family history. But as we said, you forget to mention the examination for the vital sign and the fundal level.
Okay, got your point.
Yes, regarding the result of the scan, let me confirm your name, please. As you said, the scan shows that your baby growth is less than 10 centile, and this means that your baby is smaller than expected. 10 centile means that your baby is in the smallest 10 out of 100 baby, and we use this centile as it gives us the most accurate prediction of the baby growth. Also, the scan of the umbilical artery Doppler is normal, and this means that the blood through the umbilical artery is normal, and the water around your baby is normal. Am I clear? She will say yes. She will ask you, is my baby normal? Miss Lambert, most of the baby who grow smaller are normal, but some baby may be at increased risk of serious problems as dying inside the womb or having illness after delivery, especially for those who have abnormal umbilical artery, but this is not the case. Why my baby is small? Sometimes it can happen without any apparent cause. Some lifestyle choices as smoking and heavy exercise may increase the risk of your baby to be small. And also some medical problem during pregnancy like hypertension, diabetes may do that. So I hurt my baby. Oh my God, Miss Lambert. It isn't because anything you did or anything you didn't do. Don't put blame on yourself. So what happened now, doctor? Yes, Miss Lambert, your care will be shared between us and the community midwife. You will have frequent visits and frequent checks. You will be offered a repeat scan every 2 weeks for your baby size and the umbilical artery Doppler and the middle cerebral artery Doppler. Intrapartum. Regarding your delivery, it is early now to decide how and when you will have your baby, but it will depend on the result of the scan. If it's still normal, you'll be advised to have your baby around 37 weeks. If the growth of your baby or the Doppler is abnormal, so you will advise to have your baby early. You will be referred to a specialized center called the fetal medicine unit, where the scan will be done by expert doctor. You will be advised to have your baby in a consultant-led unit. You will be offered a course of corticosteroid over 48 hours, and this to enhance the lung of your baby and prevent the breathing problem. We'll aim for the vaginal delivery if the Doppler is normal. Otherwise, you will have your baby by CS. Your baby heartbeat will be monitored continuously during delivery, and you will be given painkiller option. After delivery, they will be baby doctor, and you're allowed to breastfeed your baby, and you will be given appointment for contraception. Please don't forget to complete the cycle. The cycle of the antenatal module and the maternal medicine module will be antenatal care, intrapartum care, and the postpartum care. If you manage to complete the cycle, you are safe. You will not miss any point in your session. This is the risk factor for the small for gestational age fetus. This is from the Green Top guideline. As you know, the minor risk factor and the major risk factor. You can have a look. You know it by heart already. And as you know, if we have 3 of the minor risk factor, we will go for the uterine alto Doppler at 20 weeks. And if it's normal, we will do fetal assessment and umbilical alto Doppler in the 3rd trimester. But if the uterine artery abnormal, we will go for the umbilical artery Doppler from 26 weeks. If you have one only of the major risk factor, you will go directly to the umbilical artery Doppler from 26 weeks. And this is the management plan for the baby of a small for gestational age as per here the guideline. If you have the symphysial fundal height less than the 10th centile, or if from the history of the patient or the biochemistry of the patient, like the pregnancy associated plasma protein is low, so you will go for the fetal biometry. You will measure the estimated fetal weight or the abdominal circumference of the patient. And if it less than 10th centile, you will go for the umbilical artery Doppler. If the umbilical artery Doppler is normal, you will repeat the scan fortnightly. You will repeat it fortnightly for the Doppler, umbilical artery Doppler, and the middle cerebral artery Doppler, and the estimated fetal weight and the abdominal circumference. You will deliver this patient if all are normal, or if all are kept normal, you will deliver this patient around 37 weeks. But if the middle cerebral artery become abnormal or there is a static growth of the baby, so you will deliver around 34 weeks after corticosteroid. Okay, so if the umbilical artery Doppler is abnormal, but still there is end-diastolic velocity, what you will do? I will repeat the Doppler twice weekly, and I will deliver the patient around 37 weeks if it's still the same, but if the static growth, I will deliver the patient at 34 weeks after corticosteroid. If the umbilical artery Doppler is abnormal and there is absent or reversed in the diastolic velocity, we will do the Doppler every day, daily Doppler and the ductus venosus Doppler and the CTG. And I will deliver the patient at 32 weeks, even if all are still normal. I will deliver the patient at 32 weeks. But may I deliver the patient before 32 weeks if the CTG become abnormal or the ductus venosus Doppler become abnormal. So it is clear now.
Yes.
Yes.
Okay. Any question? Any comment?
I actually didn't have the idea that in this maternal medicine module we need to talk about like contraception also. So I didn't touch that postpartum
Yeah, you have to
area at
mention
all.
only this point that after your delivery, we will arrange a meeting, or will arrange appointment with your GP to prescribe for you the suitable method of the contraception. But you didn't, you don't have to tell her what is the contraception will be suitable for her. It is not the time now. But alert her that after pregnancy, she should go to the GP to take a suitable method of contraception.
Okay. Thank you.
Okay, welcome. Okay, so who wanted to share the second case?
Can I try?
May I share, please?
Yes, Dr. Shaima.
Yes, please.
I will start to calculate for you 2 minutes. Okay, start reading, please.
Any other information?
No. This is a structured discussion task.
Sir, please, what is CMW?
Community midwife.
And SFH?
Symphysial fundal height.
Oh, sorry, sir. Yeah. Thank you.
Okay.
Okay, doctor, I am ready.
Ready?
Yes, please.
Okay. You still have 20 seconds, but it's okay. I will start for you the 10 minutes. Okay, start please, Dr. Shaima.
Hello, I am Dr. Shaima. I am one of the exam candidates today. I have gone through the questions and I am ready to start the discussion.
Okay, Dr. Shaima. You read the instruction outside the cubicle. So what other information you wanted to know more about this patient?
First of all, I wanted to confirm that the name and the age of the patient. I wanted to ask her more details regarding her current pregnancy. Have she has been ever pregnant before? What's her parity? And if she has any previous babies? And in the current pregnancy has she been following regularly? And have she did the initial ultrasound and the down screening and if she has been following regularly with her midwife or not. And I want to ask about any current symptoms in this pregnancy. I want to ask about the fetal movement also. And I want to ask about her periods when I will ask her to tell me more about her periods, especially the date of the last menstrual period, if it has been regular before, if it has been preceded by any form of contraception, and if she has did the dating scan. I would like to review her record and check the result of the early scan, because it's very helpful to make sure that this is a proper يعني calculated date of pregnancy, because we have to exclude wrong dates. I will check the result also. Maybe she has presence, maybe she has it will show presence of maybe multiple pregnancy, or and I would like to estimate the gestational age of her now. If she has any gross scan done before or no, and if there is any gross chart that I can see if it is يعني there in the file to confirm that it is more than the 19th centile. Regarding the ultrasound assessment, if it is there, I'd like to know the exact weight and the amount of liquor. Maybe there is polyhydramnios, and this can be a cause for the increase of the fundal level found by the community midwife. I wanted to see if she has done the GTT glucose tolerance test in case she has some risk factor in her history, and in case she has abnormal glucose tolerance test, if she is يعني properly controlling that or not. I want to ask regarding any previous medical problem for her, and if she has been pregnant before, did she have the same condition as a large for age baby or no? If she has any other surgical problem regarding her social status, if she's smoking, if she takes alcohol or drugs, or what she is doing for her living, and if she has the
Okay,
proper
Dr.
support.
Okay, thank you. This is the history of the patient. You can read, please.
3 weeks.
Okay, when you finish reading, tell me, please.
Okay.
Okay.
Yes, I finished.
Okay. So what is the examination and the investigation you wanted to do for this patient now? This patient now is 33 weeks, as you see, and her body mass index is 31. And as you see, the animal scan was normal, OGT was normal. So what the examination you wanted to do, and what are the investigation you wanted to do?
I wanted to examine her after taking her permission in the presence of a chaperone to check her vitals, pulse, blood pressure, and respiratory rate, and to do examination of the abdominal examination to check the fundal height of the baby, to confirm the finding seen by the midwife, check also the presentation and clinically the amount of liquor.
And the investigation?
Investigation, I would like to do ultrasound to assess the growth of the baby, to check exactly how much in relation to the growth chart.
Okay, this is her examination. Her body mass index is 32, and this is the scan, the result of the scan. Okay, can you interpret the result of the scan for us, please?
Yes, here it's showing that the birth weight is above the 19th percentile, which diagnose large for gestational age.
Okay, so how you will manage this patient, please?
First of all, I have to explain to her that the growth of the baby is diagnosed now above the normal rate of the growth, and this can have in her condition there is she has a higher body mass index, which can be a risk for this condition. Otherwise, many of the cases there was can have other risk factors, but she doesn't have this. And I will explain to her that we need to have a regular follow-up of the fetal weight and examination of the amniotic fluid also, and that these regular follow-ups should be in a consultant-led unit, and the rest of her pregnancy, according to the growth of the baby, we may consider induction at term for her in case the weight of the baby is more than 4.5 kilogram. This induction should be done in or should be in a consultant-led unit, and we may need to do frequent assessment of the fetal heart rate by CTG, and in case there is difficulty in detecting the fetal heart rate using the transabdominal, we may need to do the fetal scalp electrode to check the fetal heart rate for proper tracing. And in the postpartum period, the baby will be examined by a baby doctor, and we are encouraging her to go for breastfeeding, and we will give her a suitable form of contraception if she wants, and I will give her some information regarding healthy diet intake. Our aim is not to reduce weight during pregnancy, but take a healthy diet during pregnancy, and postnatal we can even refer her to dietitian now, just to know what is the best dietetic options for her, and postnatal she may start to try weight if she wishes to. I will explain to her that we have to assess the risk for venous thromboembolism now, and if she has been admitted any time to the hospital, and immediately in the postpartum period, to know if she need to have any thromboembolic prophylaxis, the immediate postpartum period or even in pregnancy.
Okay, Dr. Shaima, from this history, this is the history of the patient in front of you. What do you think it may be the cause or the risk factor for her larger or gestational age baby?
Her body mass index is higher than expected. It's obese, yani type 1 obesity.
What other risk factor for? Okay, time finish. Okay, thank you, Dr. Shaima. You did very well in this difficult scenario. This case is really difficult, but if you go systematic, as we said before, it will be so easy for you. So at the start, as we said before in the structure discussion, when you start your session about any case, you start by saying, I will put a differential in my mind. So you have now a patient who has a symphysial fundal height more than 8. So what may be the cause? So you tell the examiner that I will put differential in my mind. This may be 1, 2, 3, 4, 5. So in this way, the examiner know the way that how you think, and he will start to concentrate with you. So after that, when you ask about the history of the patient, you go systematic not to miss any point, and put in your mind when you ask the patient or when you take the history of the patient to ask about the risk factor or the causes of this symphysia fundal height, why it is high. So you introduce yourself well for the examiner, and you take history good, but it wasn't in a systematic way, so you forget some point. Regarding to the model answer of this case, I will put differential in my mind. This may be wrong date. This may be large for gestational age baby. So I will ask about the risk factor of large for gestational age. This is the risk factor: high body mass index, multiplicity, pre-existing diabetes or gestational diabetes, or previous large for gestational age. This may be polyhydramnios, maybe multiple pregnancy, maybe fibroid, maybe hydrops due to infection or RH isoimmunization. So I wanted to know more of the patient from her history and from her notes. Don't forget to review the patient note. You can tell the examiner, I will review the patient note. I will ask the patient about any complaint, symptoms suggestive of diabetes, like polyuria, polydipsia, weight loss, any flu-like illness that suspect the infection. How does she appreciate her bubble movement to exclude congenital anomaly? Then regarding to the obstetric history, by the same way, obstetric, gynecological, medical, by the same way. Obstetric history, I will ask her about this current pregnancy, how far she is in this pregnancy. I will compare it with the last menstrual period to exclude wrong date. I will see or review her early scan to see whether any wrong date or it is go with the early scan or no. I will review her blood test to see the OGTT or RH. I will review her booking body mass index, because her risk factor depend on the booking body mass index, not the present her body mass index. Regarding to previous pregnancy, I will ask her about whether she has any baby before by a large gestation age, and how was the outcome, whether she delivered by cesarean section, was there any complication, the baby has any shoulder dystocia, any instrumental delivery. I will ask her about her last menstrual bit, as we said before. Regarding the medical history, I ask her about whether she has any diabetes before, any fibroid or cesarean section. The allergy will be only for safety of the patient. So this is the history of the patient. The examiner, after you finish the history, he will say thank you, take the history of the patient. This is the history of the patient. He will give you another paper by the history. So please, when he asks you about the information from the history, don't jump to the examination or the investigation. Don't jump. Be concise with the history. Okay? Show the examiner that you are safe doctor and you are concise doctor. Okay? So he will give you this information about the history of the patient. She is gravida 2/1. 33 weeks now, a positive body mass index at booking, it was 31. Her early scan was the LMB. The anomaly scan was normal. The OGTT was normal. The midwife used the customized chart for the symphyseal fundal height. The previous baby wasn't large for gestational age. It was 3.2 kilogram. No medical or surgical history at all. No allergies, no symptom of diabetes, and no flu-like illness. So the examiner now, he will go to the next question. He will ask you about the examination and the investigation. It will go by this way in the structured discussion. He will ask you first about the history, so you will answer regarding the history. Then he will ask you about the examination and the investigation, so you will tell him the examination and the investigation. And at the end, he will ask you about the treatment, so you will tell him the treatment. Don't jump to the next point unless the examiner asks you. Then what is the other point in the examination you wanted to know? I wanted to know her body mass index and the symphyseal fundal height. I will examine here to see the symphyseal fundal height, as you said. Regarding the investigation, I wanted to do scan to confirm, to see whether it is large for gestational age by the Gosset chart, the amniotic fluid, and the placenta and the presentation. It will be only for the mode of the delivery. He will give you now, the examiner will give you another paper by the result of the examination and the investigation. This paper includes that the patient body mass index now 32. The scan show that it is single viable baby, male, at 33 weeks cephalic presentation, no congenital anomaly. The placenta anterior upper and the vertical pocket is 6 cm, and the growth chart as you explain to the patient, to the examiner. You have to explain to the examiner. Don't say that it is large for gestational age alone. No, you have to tell him, as you said it very well. You said the baby weight, the estimated fetal weight is above the 19th centile, so it is large for gestational age baby. Now the examiner will come to the last question, and he will ask you what will be your management plan for this patient. You said, I will explain. Very good. You will explain this in the lay language for the patient, and this means that your baby is larger than expected. This means that your baby may be more than 4 kilograms at the time of the delivery. And explain for her that there is no apparent cause for that except her body mass index only. And what will be done for the patient now? This patient need another scan at 35 to 37 weeks, and another one at 39 to 40 weeks to confirm that it is large for gestational age. If it's still large for gestational age, so there is a possibility of macrosomia. This patient need to meet the pediatrician to explain for her what will be the outlook of her baby. Explain for her the risk of the delivery of large baby, like prolonged labor, instrumental delivery, shoulder dystocia, cesarean section, postpartum hemorrhage, and what is shoulder dystocia mean for her baby and for her. Then regarding the time and the mode of the delivery, it will be shared decision between the patient and the team. We have three options for this patient. Either it will be conservative management till the patient come in labor as any other one, or IOL at term, or elective cesarean section. I will explain for her the pros and the cons of each one. And I will tell her that we will aim for vaginal delivery, and it will be in a consultant-led unit. As you said, after delivery, the patient will allow to breastfeed her baby and give her a point of contraception. And I will give her patient information leaflet, and I will advise her to optimize her weight before her next pregnancy. This is some point from the scientific impact paper published in 2018 about the large for gestational age baby. You can have a quick look on this scientific impact paper. This scientific impact paper said that the macrosomic baby, we know what is the difference between the macrosomic baby and the large for gestational age. And in general, the macrosomic baby, the weight will be more than 4 kilogram. And as you know, all the macrosomic baby will be large for gestational age, but not all the large for gestational age baby should be macrosomic. So you may have baby large for gestational age, but when the baby is delivered, her weight will be less than 4 kilograms. So it will be not macrosomic. But all the macrosomic baby, they were large for gestational age. What is the risk factor for the large for gestational age or macrosomia? It is obesity, multiplicity, history of previous pregnancy, and history of previous pregnancy result in macrosomic baby, pre-existing or gestational diabetes. What are the risks associated with the macrosomia? As we said, operative delivery, perineal injury, postpartum hemorrhage, neonatal complication like brachial plexus injury and birth trauma. Regarding to the NICE states that the ultrasound estimation of the suspected large for gestational age not give accurate prediction than the clinical examination. So the NICE was recommended not to do ultrasound scan for the patient who suggested that it have a large for gestational age. And also the American Congress of Obstetrician and the Gynecologists say that. But regarding to the scientific impact paper, it says that from randomized controlled trial, it shows that the ultrasound scan more accurate in the antenatal prediction compared to the clinical method. So when you suspect that patient have large for gestational age, you have to do ultrasound scan in two phases. The first one, it will be at 35, 37, and the second one, 39 and to 40 weeks. And if it still have large for gestational age baby, so you will discuss with her option, the three options as we said, the induction at term, or expectant management, or cesarean section. As we know, there is clear recommendation that elective cesarean section should be offered for all diabetic women who has baby weight more than 4.5 or non-diabetic mother with estimated fetal weight more than 5 kilograms. So if the diabetic mother have baby with 4.5, elective cesarean section should be offered. Non-diabetic mother has estimated fetal weight more than 5, elective cesarean section should be offered. Okay, regarding to the patient who have baby 4 kilogram, as we said, we have 3 options, but there is strong evidence that the induction of labor is associated with substantial reduction of the shoulder dystocia and fracture without increased rate of the cesarean section. And this is the opinion or the summary of the scientific impact paper. You can go through this. Any question?
Dr. Ali, that regarding this large baby, no need to observe for next 2 weeks to check by the specialist midwife to check the blood sugar level.
Excuse me, come again. I can't hear you.
No, regarding this checking the next two weeks to ask the specialist midwife to check the blood sugar level whether it's increasing or not. With that, if is such a things, we have to be reassess blood sugar level. Is it anything that like is there for large baby?
Yes, we confirm that she did OGTT and it was normal.
Yeah, I know that, but if we diagnose fetal macrosomia, whether we had to do such a things after the another 2 weeks additionally to look for any evidence of blood sugar level is high. If it's such a condition, we had to reassess the blood sugar. Any such a management is there here? No.
Really, I don't know if we have to repeat the OGTT again or no, but I think I didn't read this point. The patient has OGTT and it was normal, so I don't know whether we have to repeat this OGTT or do blood sugar again for her or no. If you have any source for that, you can post in the group or tell us.
Okay.
Okay, thank you very much.
Excuse me, Dr. Ali, when we offer induction of labor, at what gestation we should offer? 37, 38 plus 6 or for 39?
At 40 weeks.
Okay. But at 40 weeks, there is a risk of more increase in the weight of the baby with the possible risk of shoulder dystocia.
In fact, in this scientific impact paper, they said at term, you have to induce labor at term, and they didn't define what will be at term. You know, term is 37, completed 37 weeks. So they didn't define exactly which week it will be induced, whether at 40 or 39. For my opinion, it will be at 40. But if there is risk of, as you said, for the large for gestation age, the baby will be more weight, so you will induce this patient. And remember that the repeated scan, as we said here, we have to repeat the scan at 39 and 40 weeks. You didn't take decision only on the first scan 35 to 37. You will repeat the scan again at 39 and 40 weeks. So at 40 weeks, if the scan confirm that it is this baby is large for gestation age, you will induce labor.
Yeah, so I think there is controversy because
Yes.
term you think after 37 weeks might be, but I think ACUG, American College, advised that it's better at 39 to 40 plus 6 because to decrease the neonatal morbidity and mortality.
Yes,
okay.
yes.
Okay, thank you. Thank you very much.
Thank you very much. Thank you. Okay, the third case.
Can I try, please?
Yes, Aisha, okay. Okay, I will start 2 minutes, Aisha.
All right. Okay.
Okay, start please.
Hmm. Okay.
I am finished.
All right. Can I start?
Okay, let me start 10 minutes.
Yes.
Okay, Dr. Aisha, I will adjust a minute, but we will start after the prayer, please. Okay, so wait till the prayer
Oh.
finish.
All right. Okay.
Okay. Okay, can we start? Aisha, are you here? Dr. Aisha?
Hello.
Yes, hello.
If she is not available, can I do this?
Yes. Can I do it?
Okay,
Yeah, I'm here. Yes. Dr. Lee, I'm here.
okay, Aisha. Okay, okay. Okay, Dr. Fernaz, you can do the next one, inshallah.
Okay.
Okay. Start, Dr. Aisha.
All right. Okay. Hello. I'm Dr. Aisha, one of the doc in the antenatal clinic today. May I confirm your name and age, please?
Yes, Doctor. I am Sarah Adam, and I am 35 here.
Mhm. How would you like me to address you, either with your first name or last name?
Call me Sarah, doctor.
All right, please call me Aisha. Sarah, I understand from your notes that you had previous delivery and now you want to have a home birth.
Yes.
Is that right? Yeah. All right. Apart from that, Sarah, do you have any specific concern that you would like me to address for you today?
No, doctor. Only I wanted to have my baby in my home.
Okay. So, Sarah, can you tell me before we discuss the options for you to have a delivery at home or for the plan for you? So, is it okay if I can ask you a few questions to know more about you as we're meeting for the first time? May need to examine you in the presence of chaperone, would run some tests for you, and then together we can discuss about your management options. Will that be
Okay.
okay with you, Sarah?
Okay, doctor.
Right.
No problem.
Thank you, Sarah. So, Sarah, can you tell me more about your pregnancy?
Yes, my pregnancy is an eventual pregnancy. All everything is normal. I follow my midwife, and
Mm-hmm.
I did my early scan. It was normal, and my anomaly scan was normal. Down syndrome was normal, and I did all my tests, and all my tests are normal. So please, doctor, everything is okay. I wanted to have my baby at my home.
Mm-hmm. Sarah, is there any specific reason that you want to have a home birth?
Yes, doctor. You don't know what happened for me in the first delivery. I
Yes,
has a
Sarah, I
horrible
did read.
experience.
Mm-hmm. Yes, yes, Sarah. Please explain. Tell me in your own words, if you.
Yes, doctor. I have my baby in the hospital,
Mm-hmm.
and I was following my midwife, and she told me that I have to have my baby in the hospital, and I came to the hospital. I start my labor natural, and I was first in the pool, and my water broken off spontaneously. But they said that my baby did a poo or open bowel in my tummy, and they
Mm-hmm.
monitor my baby heartbeats. And suddenly they rushed me to the theater, and they did emergency section without telling me anything.
Mm-hmm. Mm-hmm. I'm really very sorry, Sarah, to hear that what else happened last time. So let me assure you that for this pregnancy that you are going on, we'll make sure that everything upon for your up to your expectations. All right, Sarah.
Okay, doctor.
Thank you. So, Sarah, can you tell me how many weeks you are into this pregnancy?
Yes, now I'm 34 weeks.
Mm-hmm. And how's the baby? Have you named your baby?
I name my baby? Yes, my baby Tom.
Ah, so how is Tom? Is Tom happy inside your tummy?
How? Excuse me?
Is Tom is Tom kicking inside your tummy?
Yes, yes, everything is okay.
All right, that's good to hear. And apart
Thank
from this, apart from this, when was your last? You told me your periods were your periods regular prior to that?
Yes,
Mm-hmm. What about your cervical smears? Are they normal and updated?
yes, it was normal and up to date.
Mm-hmm. All right, okay. And are you following with your GP for any other medical problem like diabetes, hypertension?
No,
Mm-hmm. All right. Any operation apart from this surgery? Any other operation on your tummy or down below?
no,
Any family history of concern that you would like to share with me, Sarah?
no, no.
Mhm. Are you taking any medications at the moment?
Only vitamins.
Okay. Are you allergic to any medication or food substance that you are aware of?
No,
hmm And do you smoke, Sarah?
no at all.
That's really good. Drink alcohol?
No,
Use of any recreational drug?
no.
hmm And with whom you are living, Sarah?
My partner.
hmm Do you feel safe and happy at home?
Yes, he
Oh,
loved me very much.
that's brilliant to hear. And sir, what do you do for living?
I'm a housewife.
All right, that's good. And in the past 4 weeks, have you ever been bothered by feeling depressed or low down?
No, at all, doctor.
hmm In the past 4 weeks, have you ever been bothered by feeling lack of interest in activities that usually used to enjoy before?
No.
hmm And Sarah, do you know your blood group?
Yes, it is all positive.
All right. And your BMI?
Yes, it is 28.
All right. Okay. All right, Sarah, thank you for sharing all the information with me. Is there anything else that you would like to add?
No, doctor, except please, I wanted to have home birth.
Yes, Sarah, I'll be just coming to your concern in a bit moment. So, Sarah, what I'll do, I'll ask my nurse to check your blood pressure, pulse, temperature, and how fast you are breathing. And I would like to see your tummy to see how your baby is doing and how Tom is doing inside your tummy. Will that be okay with you?
Okay.
All right, thank you for that, Sarah. So, Sarah, now coming to your concern that you wanted to have a home birth, it's really a very good option to have a home birth. You can have your partner will be with you. You'll be supported by your family members during, and there's a very less chance that you may need any intervention, and everything will be so smooth and easy. You will be more comfortable at home as well. But Sarah, there are some concerns with home delivery. So I would like to explain you. Will that be okay?
Okay, doctor, like what?
Yeah, Sarah, as you had a previous cesarean section, as you had a previous operation done on your tummy, so it is very difficult for us to monitor your baby at home because there is a scar on your tummy. So, and we need to monitor the heartbeat of the baby once you go into labor, because because once you go into the labor, there's a small chance that the scar may open up or the scar may tear off. So for that, we need to keep a continuous eye on the baby's heartbeat by putting straps around your tummy. So, but that won't be available at home for us to do. And if something
Okay,
happens
doctor,
that
you
either
tell
your
me that
scar,
my scar, doctor, you tell me that my scar will open. How much is the chance? How much is the percentage my scar will open?
sir, it is around 1 out of 200 women like you who have this
So
operation done.
it is too little, doctor. It is still little chance. So you try to scare me not to have a home birth, and really I will not come to the hospital to have my baby. I know if I come to the hospital, it will end by cesarean section. So I will not come to the hospital by any mean.
Mhm. No, Sarah, let me assure you that we all the doctors who will be taking care of you throughout the labor, they are well trained enough to support you in your decision that if you want to go ahead with a normal. And we also make sure that you try to have as much natural birth as possible for you, because doing an operation has its own risk associated with it, because sometimes because doing an operation, as you previously also had an operation done, so it will be a more difficult operation because of the previous scar, and it will also take more time for the baby to be delivered. And there are also increased chances of having injury to your surrounding organs like bowel, bladder. So that is why, but still, and along with that there are some, and along with that it will, if we had and along with that, if you had a operation done, if you have a home birth done, if you had an operation done again, then it will be, you need some time to recover after the operation, and also there will be increased chance of having blood clot. So for that we may need to put you onto some blood thinning injections, but for that we'll be assessing you afterwards after the delivery. Are you with
Hmm?
me, Sarah?
Yes, doctor, I am following you, but I wanted to have my baby in home. You don't know what happened. I have infection after my first operation, and it take too long time to heal. So I don't want this history to happen again, please.
Yes, Sarah, I can really see that you're really worried for what happened previously. Once again, I'm really sorry for what happened, but we'll make sure that this does not happen again. And we'll make sure that a midwife is there with you at all the time. And as
Trying
with
to
your,
try.
okay, okay.
Okay.
Can I continue?
Time
Okay, can I
finish.
continue?
Okay, you can complete. Okay, you
All
can go
right.
on.
Yeah. So as for your infection, as you're really worried for the infection, so for that we'll make sure that we'll give you appropriate antibiotics, so that, and we'll take all the precautionary measures, sterilization measures, so that you don't get the infection that happened previously. So for now, Sarah, if you, so for now, Sarah, what I would like to do, I would like to do arrange your appointment with my consultant, as you can speak to him as well about your place of birth. All right.
Okay.
And I'll give you the written information about the home birth versus the hospital delivery, so that you can make up your mind, you read at home, make up your mind, discuss with your partner, and once you're ready, you can decide and let us know back to it. And meanwhile, I'll write back to your GP as well. Okay.
Okay, Dr. Aisha.
Thank you.
Okay, so if I want to water pairs, it will be suitable for me.
No.
Why?
uh, uh, yes, you can have the option of telebirth, but still it would be difficult. Monitoring will be difficult.
I know that there is something that you can monitor my baby without any wire. It is wireless monitoring. If
Mm-hmm.
available in your hospital?
Sir, at the moment, I'm not sure about this, but I'll let you know after discussing with my consultant about it.
Okay. Also, doctor, I don't want to have a cut or episiotomy. So you have to do episiotomy for me in the next time.
Sarah, it's not necessary for each and every woman to give a cut down below. But if it is necessary that the baby, that your Tom is having difficulty at the time of delivery, or is not delivering, or is not happy inside your womb, then at that time we may need to assess you and give you the cut down below accordingly.
Okay. Okay, doctor.
Okay.
Okay, Dr. Aisha. Thank you.
All right. Thank you.
Thank you. Well done, Dr. Aisha. You did well in this case. I know that the role player was tough with you. uh, and so it is very difficult time when you face a role player tough, or she has a bad scenario or a bad history about something. So from the start, you have to take the patient in your side and assure her about her autonomy from the first moment. You have to do this so you can make the patient calm and relieve her anxiety. If you assure her about her autonomy from the start, you introduce yourself very well and you greet the patient. uh, you asked her about what would you like to call you. Some may prefer this question and some not prefer. Okay, it will be for you. Do what do you think regarding this? But regarding it, you can call me Aisha. I think it will be not reasonable. You didn't do that in your daily life, in your clinic. You didn't tell the patient what is your name. She will say, my name is Sarah. You can say, tell me, you can call me Ali. It is not reasonable. So you can delete this or don't say that. Okay. Uh, after that, you check the purpose of the meeting very well. And as I said, you have to assure the patient from the first moment about her autonomy by saying, Sarah, I am here today to address all your concern, and I will try to answer all your questions. But at the end, the decision is yours. So from the first moment, the patient will know that you will not enforce her or force her about something, and this it will be open discussion, and you will tell her about her option, and she have to choose. After that, you put the agenda very well. You take a history in a systematic way, so you didn't miss any point, except one point in the obstetric history. You forget to ask her about future pregnancy. what is her plan for future pregnancy. Because if this patient need or want more babies, like 4 babies or 5 babies, so vaginal delivery will be the best suitable option for her. If she need 1 or 2 babies, so elective section may be suitable for her. So you have to ask about the future plan of delivery. Okay, and then you go through the history very well, and at the end you ask her about any other concern, any other question you want to tell me, and you examine her in the presence of chaperone. Coming to her concern, you start by the good point in the home pairs. Very good. You assure the patient about saying the good option or the good point in the home delivery, and after that you warn her from the home pairs. You go well in doing that, and you wasn't judgmental in explaining the option. You don't tell her that we have to do, you have to do. We say we see that all of this may give a bad impression about you for the role player and for the examiner. You make an open discussion, you take her opinion, and at the end you give her appointment to this consultant, and you give her a patient information leaflet to read, and she can discuss this with her partner, and she come again to have a friendly talk with your consultant. So we can go to the model answer of this scenario.
Yes.
You greet and introduce yourself and confirm the identity. You check the purpose of the meeting, and as I said, autonomy. You have to assure the patient about her autonomy. I am here today to address all your concern, and I will try to answer all your question. At the end, the decision is yours. Okay, I know that you are here today to put a plan of your management, but I wanted to ask you some question to know more about you, and you take the history of the patient, static history. It will be in the past. Could you tell me more about your previous pregnancy? What happened? She will tell you the scenario, the history, what happened, and why you have cesarean section. She will tell you that my baby opened her bowel in my tummy and they rush me in the theater without telling me anything. Oh, I am sorry for that. I'm sorry if you find the care that you made didn't match your expectation. Okay, try to express emotion and for the patient. She said yes, and I have an infection, and this infection take long time to heal. Sarah, I am so sorry. Yes, infection can happen, especially after emergency section. Then you ask her about the current history. Could you tell me more about this pregnancy and what is the scan, the result of the scan, future pregnancy? You forget to ask about that, and she will tell you, I want to have 4 children. So a vaginal delivery will be best option for her. You went through the gynecological, medical, surgical, and allergy. Very good. You didn't forget psychological history, good family history. Examination, you examine her and you forget to review her notes. It's very important point, especially in the patient with previous cesarean section, to know to review the note. It is a part of the information gathering. If you didn't mention that, you will lose a mark here. Sarah, you have to tell her that. So the examiner will mark in his sheet. He have a sheet mark. So he will mark a sheet. He will mark in his sheet that you review the patient note. You have to open her file and see why she has cesarean section and how her recovery, and any recommendation from her surgeon. Maybe her surgeon do recommendation to be opened at 36 weeks or 37 weeks, not at 39. She may have a large extension during the cesarean section, like this. So you have to open the patient note and tell her that, so to see any recommendation from your surgeon. Also, I wanted to review your scan. She may be small for gestational age, she may be large for gestational age, and the result. So you have to review the patient note, examination, you said that, and examine her tummy for the growth of the patient. Coming to your concern today, could you tell me why you have you wanted to have home birth? She will say like that. Okay, home birth is a good option because you will be surrounded by a lot of people that you may know. and you will have your baby you in a place that you are familiar, and you will have early skin-to-skin contact and early breastfeeding. But Sarah, I am sorry, it may be not suitable for you, and try to draw for her. Draw in any case. Put in your mind, you will draw in every case as you can, or say that for yourself. Say that before the exam for yourself. I will draw for every case, except some cases we will tell you later. It will not be reasonable to draw, like breaking bad news. So put this in your mind. I will draw in every case, but because of drawing, it is a good communication with the patient. Okay, Sarah, if you let me explain for you. You will draw a womb and a baby inside the womb. You have a scar here and the womb here. So during delivery, this scar may be opened, and it may happen in about 1 in 200. And in this case, you may need emergency section. Also, Sarah, most of the women, about 3 in 4, who have straightforward pregnancy and their labor started natural, will have vaginal delivery, but still 1 in 4 may need cesarean section. Also, the baby may need to be monitored continuously during your delivery, as any abnormality of the heartbeat may be a sign of opening of the scar site. So at that time, you will need emergency cesarean section. So from this, Sarah, I strongly advise you to have your baby in a place in the hospital where the facility of emergency section will be available. What do you think, Sarah? She still said, no, doctor, I wanted to have a home birth. Sarah, I understand your concern, but at home, if any emergency arises, it will take time to reach the hospital. So this puts you at your baby at a risk of bleeding and even death. She will say, I know, doctor, if I come to deliver in the hospital, it will end by cesarean section. Sarah.
Yeah.
Again, I understand your concern, but I want to tell you that each pregnancy has its own circumstances and its situation. Your baby, you and your baby safety is our priority. In case you insist, Sarah, to have your baby at home, we can arrange a compromise. What is a compromise here? Compromise here may be alongside midwifery unit. As you know, in England, there are 4 sites of delivery, maybe home, a freestanding midwifery unit. It will be far away from the hospital, or alongside midwifery unit, it will be beside the hospital. So here it will be alongside midwifery unit. If any emergency, we can transfer you up to the hospital in case of any emergency. Also, Sarah, I can arrange an appointment with my consultant. You can come with your partner to have a friendly talk. Okay, doctor. Okay, if I come to the hospital, can I have water birth? Sarah, I will check if there is availability of the telemetry. What is telemetry? Telemetry, it is a wireless CTG. You can put the probe of the or the toco and the cardio tocography, and you monitor the baby while the patient in the pool. And if any concern about the baby heartbeat, we will ask the patient to come out of the pool. Okay, doctor, I don't want episiotomy. Yes, as you said, Aisha, episiotomy will not done in every case. We will do it only if the baby is distressed or we need a instrumental delivery. Okay, doctor, I don't want instrumental delivery. Okay, Sarah, we will not do this without your consent. In some cases, only we need to do instrumental delivery, like if the baby is distressed. Okay, doctor, I want intermittent auscultation, not continuous monitoring. Sarah, we need to monitor your baby. You don't tell her, no, I will do continuous monitoring. No, I will do instrument. No, take it gentle and try to negotiate the patient by a good way. Sarah, we will need to monitor your baby's heartbeat continuously during delivery, as any abnormalities of the heartbeat may be early sign of opening of the scar. So at that time, we may need cesarean section. Am I clear, Sarah? She will say yes. And if time allow you to give her pros and cons of the VBAC versus elective cesarean section, this is from the patient information leaflet. You have to go through this patient information leaflet of the VBAC. It is very, very important to know about the pros and the cons. Sarah, having the vaginal delivery will be a good option. you will now talk about the pros. You will likely have a vaginal delivery in next pregnancy, especially you want 4 children. Also, you will have early skin-to-skin contact, early breastfeeding, and shorter hospital stay, rapid recovery, and avoid surgery. But there is some risks of the vaginal delivery, like you may need cesarean section about 24, and there may be open of the scar. It will be 1 in 200 risk of the blood transfusion. Sarah, do you have any concern regarding blood transfusion? It will be safety point here. So as you know, the patient coming for VBAC or elective section, she is at a risk to have blood transfusion. So you should ask her about any concern regarding blood transfusion. She may be Jehovah's Witness and she refused blood transfusion, and you have to document in your notes. So Sarah, do you have any concern regarding blood transfusion? She will say no, doctor, no problem at all. Okay. If she said no, yes, doctor, you have to ask her about which type of the blood you don't want. She may say, I don't want to have bagged RBCs. She may say, no, I don't want to have plasma. So you will have to write this. Okay. Any concern regarding blood transfusion? Okay. Then you may have cut in the muscle around the back passage, perineal tear, third and fourth degree perineal tear, instrumental delivery, injury of the brain of your baby. By having a cesarean section, elective repeated cesarean section, you will avoid the risk of the labor and to you and your baby, and there is a small risk of rupture, and you may choose the date. However, 1 in 10 may go in labor before the due date. Regarding to the cons or the risks of the cesarean section, there is a risk of the repeated surgery. As you said, Aisha, you said this in a good way. It will be longer and difficult to the scar. They may be damage the bladder and intestine, blood clot in the leg or the lung, risk of infection, injury to the skin of your baby, difficult removing the placenta, may need hysterectomy, and breathing problem to your baby. Am I clear so far? So, Sarah, you don't have to choose right now. You can take time, discuss this with your partner, and I will arrange a meeting with my consultant. I will give you now patient information leaflet. Very important to mention patient information leaflet in the examination, because they made this patient information leaflet for the patient, so you have to give it for the patient. I will give you now patient information leaflet about the vaginal pairs after cesarean section, and I will give you a contact number in case you have any query. Okay, do you have any other question? Thank you. Okay.
Yes.
Sometimes I saw this written. If she asks you, okay, doctor, I want to home birth, she insists to have home birth. How we can home birth safe? This will be by ultrasound of the birth weight and the placenta, expert midwife, intravenous access, low threshold for the transfer, such as slow progress. Transport service will be available, and the hospital informed early by telephone. Okay, thank you, Aisha, very much.
Thank you so much. Thank you so much, Dr. Ali.
Thank you. Fourth case. Anyone want to share? Hello.
Hello.
Hello. Farnaz.
Hello. Yes, sir.
Okay,
Hello.
Dr. Farnaz.
Yes.
You can take 2 minutes.
Okay.
Okay. Okay, start now. 2 minutes. Start.
Okay.
Okay.
Hello.
So we'll start 10 minutes. Okay, start.
Okay.
Hello.
Hello. I am Dr. Sarvat, one of the Dr. Antenatal Clinic. May I confirm your name and age, please?
Yes, doctor. I am Mary Goodnight, and I am 25 years.
What would you like me to call you?
Call me Mary.
Mary, I understand that you are pregnant and you are having a disease called grave disease. Am I right?
Yes.
Any other concerns you want to discuss today?
Doctor, I am afraid of about my baby. As you know, I have a Graves' disease, and I took medication for that, and I am afraid about the effect of this drug on my baby.
Okay. Yes, I can see you are more concerned about your baby. So,
Yes.
as I am seeing you first time, Mary, so I would like to ask some questions to know more about you. Then I will examine you and may need to run some tests if required. And together we will discuss the management. How is that sounds to you?
Okay, doctor, welcome.
So tell me more about your condition. How long you are having this problem and what medicine are you taking?
Yes, it was since 6 months when my heartbeat started to become faster, and I started to become irritable, anxious with my partner. So my partner took me to the medical doctor, and he did some test for me, and he said that I have overactivity of my thyroid. My thyroid produce more hormone, and he started to prescribe for me some medication. And since that time, I go on my medication regular, and I feel I am good,
So,
more than
good.
before.
Okay. So tell me what medicines are you taking?
Yes, I take a drug called propylthiouracil, and another drug called Indral.
Okay. So how are you feeling now?
I am fine. I am better than before.
When did you attend your doctor?
Yes, it was since
Mm-hmm.
4 weeks, immediately before
Mm-hmm.
my pregnancy. Yeah.
Okay. Apart from this medicine, did you ever attend any investigation like iodine or any other therapy?
No, no.
No. Okay. So tell me about your pregnancy. Is it your planned pregnancy?
Yes, yes. I am planning for that. Yes.
Mm-hmm. Congratulations. So
Thank you.
tell me, okay. So are you taking folic acid?
Yes, I started to take my folic. Yes,
Mm-hmm. How much? Mm-hmm.
400, 400.
Mm-hmm. Okay. So do you have any problem like nausea, vomiting, any other problem during this pregnancy?
No,
Is this your
no
first
at all.
pregnancy?
Yes, this is my first
Is
one.
this your?
Yes.
Mm-hmm. Okay. So previously your periods were regular.
Again, come again, please.
Uh, uh, previously your cycles were regular
Yes, it was
previously.
regular.
Mm.
Yes.
Mm. You are update. Your smear was done.
Yes,
You
it
are
is up.
25
It's
years.
up to date. Yes, I did it once, and it is normal. Yes.
Okay. So, any other, apart from this grave disease, any other medical problem? Diabetes,
No, no, no at
hypertension,
all.
any
No,
other illness? Mm-hmm.
no, no,
Okay. So, any history of the clots in legs or lungs?
no, no,
Any family history
no,
of any diabetes, hypertension, any uh,
no,
thyroid disease?
no, no, no at all.
Okay. Any history of the surgery on the tummy or low down?
No,
Okay. So, some personal question. Do you smoke?
no,
Hello. Take alcohol.
no,
Any recreation medicine?
no, no at all, doctor.
Okay. So, what do you do for living?
I am a
Hello.
housewife. Yes, please,
Uh,
other doctor, please mute yourself.
hello.
Please mute yourself. Hello, hello.
Hello. What do you do for living?
I am a
Uh,
housewife.
okay. So, who support you? Your partner?
My partner.
Yeah.
Yes,
So, are you happy and safe with him?
yes, my partner love me very much.
Nice to hear. Good to hear. So, uh, coming to the, I would like to examine you. If you agree, in the
Okay.
presence of Chevron, my midwife will check your blood pressure, pulse, weight, and height to calculate your BMI. Okay. So
Okay.
then I will. Okay. So Mary, here are the some tests. First of all, I will confirm your name, an age, an NHS number on it. Here is your
Okay.
TSH level, which is thyroid hormone level, which is normal, and your T3 and T4 levels. These are the hormones level, thyroid hormone level, which are slightly high.
Okay.
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 So now come to the management. So yeah, Mary, you are having a condition which is called the Graves disease. Are you aware what is this disease? Hmm.
So sorry.
Hello.
Sorry.
Are you aware of it? Your problems of
Yes.
Graves disease?
Yes, I know that I have more hormone secreted from my thyroid.
Mm-hmm.
Mm.
Okay. So, but now that your TSH level is normal and your hormones level are slightly high. So, what happens? I will discuss about the pregnancy effect on the disease and about the disease effect on the pregnancy. So,
Yeah.
what what the
So
pregnancy effect on the disease? Pregnancy do not have any much effect on the disease. As this is a autoimmune disease, the immunity sometimes suppressed during the pregnancy, especially during the later half. So the disease become more controlled. Okay? So, but
Okay.
it is a it is very good when you enter into the pregnancy when you have the control. So first of all, I will send you to the doctor, your doctor. So you will visit your endocrinologist, your thyroid doctor. So he will review your medicines. So till that time, you have to continue your propyl thyroxine. Is the most safe drug during the early pregnancy. Okay,
Okay.
but
Okay.
remember, okay. So like the other movements, we will do
So
all the
it is safe,
screening.
doctor, to take this medication.
Yes, you are taking enrol, which is for the control of your pulse, and this enrol has some effect on the baby growth because of the growth of the baby. But we will advise you to continue it, and you will attend your doctor. Okay.
Okay. And regarding the other one, propylthyroxine.
But propyl thyroxine you are using, and it is also the in the early pregnancy. It is safe. You will continue your medicine, and you will be reviewed by your doctor,
Okay.
thyroid doctor. Okay.
Okay.
So, what the disease effect on the pregnancy? It is not causing any problem to the babies.
Doctor, you said that my
We will
my,
do.
my hormone is high. Sorry for interrupting you. My T3 and T4 is slightly high. So when I saw my doctor in the last time, he said he may give me radioactive iodine if my thyroid not controlling well. So it is safe to take this drug.
No, this is a iodine is not safe during the pregnancy.
Oh,
So
I'm sorry. Time
the
finish.
woman, yeah,
Time
okay.
finish.
So,
Very nice. Okay, you
may I
can
continue?
complete. Go. Go and
Okay,
complete.
but you have to continue. You have to continue this medicine during the pregnancy, and you will see by the that iodine is not safe during the pregnancy. But you can do this treatment after the delivery. Okay.
Okay.
So,
Okay.
like the other movements, we will monitor the growth of the baby. You may require the frequent scans during the baby. Will do anomaly scan at 20 weeks, and your medicine will be changed by the other medicine if your doctor agrees uh, later in the pregnancy. Okay. So,
Okay.
regarding the mode of the delivery, it is not an indication for the cesarean section, but may be required for the other obstetric reason. So we'll assist you in the later pregnancy. And right now, and whenever you will be admitted during the labor, we'll assist you for the clot because there is a risk of the clot formation in the legs and lungs. So we'll assist you. Or may start some blood thinning agent. Okay.
Okay. Okay.
So after the delivery, we will do the check the level of the thyroid hormones of your baby also, and your we will give one of the injection to make the womb more contracted, and you will be seen by the anesthetist, and we will discuss with you the pain relief during the labor. Okay?
Okay. Okay.
And after the delivery, it is a good idea to have some birth spacing. So we'll discuss with you the safe and effective contraception. Any questions so far?
Okay. Thank you.
Okay, welcome.
Thank you. Thank you, Dr. Afanaz. You did well in the case, but the point is the time, how you can manage your time, because only you have 10 minutes during the session. So by
Hmm. There
practice,
was some disturbance during in between.
what?
There was some disturbance.
Yes, there was some disturbance for noise from other
Yeah, yeah.
colleague, but okay, by practice, inshallah, you will do and you can manage your time in 10 minutes. You take more time in taking a history, so try to be faster in taking the history. But I see that you go systematic by practice it daily by your partner or by even you can alone do this. You will manage to finish the history in 3 to 4 minutes, not more than this. Regarding this patient came in our exam. It was a straightforward case about the maternal medicine module. This case of Graves' disease, and I think it is the first time to appear in part 3 examination. You introduce yourself well to the patient and you greet the patient, confirm the identity and check the purpose of the patient. Then you put your agenda, very good. You ask her about her symptom right now, about the present illness, good. And you ask her about her pregnancy. But the thing I wanted to ask you, when you ask her about whether it planned pregnancy or no, she tell you it is planned pregnancy. You said congratulations. I know that you said congratulations, but congratulations from you come by no feeling at all. I feel that you there is no feeling at all in your congratulation.
Yes,
You
yes,
said
you're
it,
right.
you said congratulations, like if you are angry from the patient, like this. So you have to show the patient that you are happy that she is pregnant. So smile, it will appear in face to face to the role player, but the feeling not appear in your voice. So congratulations by this way. Okay. Then you go through the remaining of the history very well. You ask about all the item. I think you forget the psychological history. You forget to ask about the two holy question of psychological illness, and it is one of the safety point. This patient in early pregnancy, so you have to ask her. Then regarding to the examination you did, the examination, and coming to explaining the result of the patient, you said I wanted to confirm your name and the age, and you didn't ask the patient about her name and age. Hello.
I want to show that I am confirmed. I have confirmed your name on this result. I want to.
Okay. Okay, but it will be better if you tell her, can I confirm your name and the age, please, again? She will say, yes, Mary, good night, and I am 25, or my date is 18 October 1981. Okay, like this. Okay, Furnace?
So it will show that I can't remember the name. So I remember the name. She's Mary. So I will show her. I have checked your name on this result.
Okay. Then you explain the result of her test. Then you go to the management plan, as we will see now. Okay, coming to the model of answer. You have to greet and introduce yourself to the patient, confirm the identity, check the purpose of the meeting, as we said. You check for any other concern. She will say, yes, I am worried about my baby because I took this drug. Yes, I can see how worried you are. I will discuss this with you, and we will discuss the management plan. But if you don't mind, can I ask you some questions to know more about you? You will ask about her present illness. Okay, the disease, any symptom like awareness of your heartbeat, weight loss, tremors, problem in vision, swelling in the neck, and when was the last consultation? Any medication? She will say yes, provide Cyrocil and the Enderal. Are you still taking this medication? She will say yes. Okay. At this point, when the patient came in the maternal medicine module and she is still taking her medication, you have to appreciate that she didn't stop her medication unless by medical advice. Even if the patient take a dangerous drug, like in epilepsy, she take carbamazine or any other drug, or sodium valproate, the best, you have to tell the patient that the good thing that you don't stop the drug unless by a consultation by a specialist. I'm sorry, there is a noise. Can you mute yourself, please? Okay, thank you. It's good that you don't stop your medication till you see your specialist. I wanted to assure you that both drugs are safe, propylthiouracil and Indral. In a recent recommendation, she said, yes, my specialist was said that I may need radioactive iodine or surgery. Mary, we do not recommend the radioactive iodine during a pregnancy, as it may affect the development of your baby. It may affect the thyroid gland of your baby. Also, surgery, we may need it in a rare case when the medical treatment failed or there is a compression by the thyroid gland on the other structure. Am I clear? She will say, yes, doctor. Then come to the obstetric history. It is planned pregnancy. She said, yes, congratulations. Could you tell me more about this pregnancy? She will say, I am 7 weeks and everything is okay. Did you have any scan? No. Ask about past pregnancy. Have you ever been pregnant before? She will say, for example, yes. Could you tell me more about this? Yes, I have a one vaginal delivery and there was no complication. Okay. And what is your future plan of pregnancy? She will say, I wanted to have 3 children. Okay. Gynecological history, because she is 25 years, so we will ask her about the cervical smear. Any other medical problem at all? Are you following your GP for any other medical problem? Any surgery at all in your tummy or pelvis? Any allergies at all? Do you use folic acid? Do you smoke, as you asked about smoking and alcohol? No. And what do you do for a living? Are you with someone right now? She will say, yes, my partner and he is supportive. Psychological history, you forget to ask about this. Any family history of medical problem? Do you want to add anything? Thank you for sharing this information with me today. As you said, I wanted to examine you, the presence of chaperone after your concern, and coming to the disease, the effect of the disease on the pregnancy and the effect of the pregnancy on the disease, as you said. Mary, most of the pregnant women with Graves' disease will have healthy pregnancy and healthy baby. However, some women may have a high blood pressure, and sometimes it will be accompanied with protein in the urine, and it's called preeclampsia. Also, there may be placental separation, and this causes bleeding. This is risky for you and your baby. Also, the baby may be smaller than expected, and the baby may be delivered before the due date. It's called preterm delivery. And also, your baby may have overactivity of the thyroid gland, and this due to the passage of the antibody through the placenta to your baby, or underactivity due to the effect of the drug. So, Mary, your care, as we said, you have to complete the cycle: antenatal, intrapartum, and postpartum. So in the maternal medicine module, you will discuss with the patient the effect of the disease on the pregnancy in the start and the effect of the pregnancy on the disease. Then you will go to complete the cycle: hair care, antenatal, and intrapartum and postpartum. Regarding to her antenatal care, it will be multidisciplinary team. You forget to mention that. And as I said in my first session, they like this word very much, multidisciplinary team. You will not tell that by this language to the because it will be considered as a jargon. If you say multidisciplinary team, it will be say in a lay language. Your care will be under a group of doctor, which include obstetrician and your hormone doctor and specialized nurse. I will refer you to your specialist as your thyroid function test is slightly high. So you may need to adjust your medication, okay, because her thyroid function test is high. The TSH as we see here. Here, TSH is normal, but the T3 and the T4 is slightly high. So the patient need to be referred again to her specialist to adjust her medication. You may need to repeat your thyroid function test monthly. Continue your medication unless your specialist has another opinion. But you should report any sign of infection like sore throat, as this drug may cause a granulocytosis. And you have to say what is a granulocytosis. If you mention any jargon in the exam, you have to express it or to explain it in a lay language. It is decrease in white blood cells which fight the infection. So you may need to repeat to follow that by repeated CBC. You may need blood test to check for the level of the antibody in your blood. You will continue folic 400 microgram. Then you need to offer your routine test like hepatitis B, HIV, syphilis, rubella, and urine test to check for any infection, CBC and blood group, and antibody against the RBCs. This is a routine screening test done for all pregnant women. You have to mention all of this for the patient in the antenatal care. You will be offered your routine scan and dating scan, anomaly scan, and growth scan. Regarding to delivery, this is the intrapartum care. It is early now to decide how and when you will have your baby. However, we will aim for vaginal delivery, and it will be in a consultant-led unit, monitor of your baby, and you will give you pain relief option. Okay, fix this 3 points in all intrapartum care, so you will not forget any point of this. Okay, regarding to postpartum, also in the postpartum, fix 3 points: baby doctor, breastfeeding, and contraception. Okay, so make a template like this. In the intrapartum, it will be in a consultant led because she has maternal. We are talking about maternal medicine. So if this patient will have a disease like hypertension, diabetes, sickle cell disease, thalassemia, any disease. So it will be in a consultant led unit, continuous monitoring of the baby, pain relief option. And you may mention some of the pain relief option. Postpartum, there will be a baby doctor to check your baby. There will be blood test for your baby, like thyroid function test, and you allow to breastfeed your baby even if you are on this medication. It is safe for your baby. It is very important to assure the patient about the safety of the drug when she breastfeed her baby, even if she is still taking this medication. You have to mention that, and we will give you, as you said, appointment for contraception, and repeat your thyroid function test, and give you appointment with your specialist. Any questions so far? She will say, no, doctor, thank you. Okay, now I will give you some of the patient information leaflet to read about your disease in pregnancy, and I will give you contact number in case if you have any query. Okay, thank you. Okay, any question?
Thank you, sir.
Thank you, Dr. Fernandez.
Yes, Dr. Ali, in the exam, how did the role play ask? She did ask about radioactive iodine in the real exam scenario.
Yes, she asked about the radioactive iodine.
And what else? Any other question the role player did ask?
For my role player, she didn't, because I mentioned all this point, so I didn't give her time. I didn't give her a chance to ask me. She has her question in her mind about the radioactive iodine. So she asked me about that, and I tell her that it will be not suitable during a pregnancy because it affects her baby. And you have to refer the patient and to differ for her specialist. You have to mention her specialist doctor, share her specialist hormone doctor. If you are not sure about anything, for example, the propylseracil, it will be safe or no, she may ask you, can I change it to carbimazole, doctor? You may not read over Graves' disease before your exam. So if you are not sure about that, so defer her to her specialist doctor, Mary. I am not sure whether it will be suitable for you to use this drug. So I refer you to your specialist doctor to see whether it is safe for you to take this drug or no, whether we can change it to a baby-friendly drug or no, if you are not sure. But if you are sure it is safe drug, you have to mention that.
All right.
Okay,
Thank you so much.
welcome. You want to complete or to stop?
Hello, Dr. Ali. Hi.
Hello, Dr.
Hi.
Salma.
Yes, can I ask you one question?
Okay, you can.
Yeah. So, if patient, you will explain about the Graves' disease, first of all, that she knows or not. So, how you'll explain the Graves' disease in lay language?
Yes, it is an overactivity of your thyroid gland. This means that your thyroid gland is the two pair of the gland over your windpipe. The trachea in the lay language called windpipe. So it is a pair of gland in front of windpipe, and it produces a lot of hormone thyroid. This hormone may make you feel your heartbeat more faster, and you may lose weight, and you may have tremors in your hand, like this.
Right. And also antibody will develop antibody also.
Yes, regarding to the cause of that, when you coming to it, she will ask you what will be the cause of that, doctor. What is the cause of that? You may ask if there is antibody against the thyroid gland, against your own the cells of the thyroid gland, and this antibody attack your gland, and it make it to produce a lot of hormone.
Yeah.
Simple language. Even if you didn't read it before your exam, you can face that in the exam. You can face any other scenario or any other jargon. So you may draw, even if you don't know how to explain the thyroid gland. Draw the trachea, and here is a gland called the thyroid in front of your windpipe, and it secretes hormone called the thyroid hormone. In your case, your thyroid hormone is a lot more than normal.
Yeah. Thank you very much.
Okay, Salma. Welcome, Salma. We still have some cases like breaking bad news and the teenager with diabetes. Marfan syndrome. Okay, we can stop here. We'll arrange another meeting, inshallah.
It's up to you.
Okay. If anyone wanted to share one more case, we can take just 5 minutes and we can do one more case. So we will finish the fifth one. If anyone wanted to share.
Yes, doctor, I want to share.
Okay. Okay, I can see Dr. Barawin.
Perwin.
Karwin.
Perwin, yes. P, yes.
Okay. Karwin. Okay. Dr. Karwin, you can read
Yes.
the scenario. Okay, I will start 2 minutes. Let me just start 2 minutes for you. Okay. Okay, 2 minute finish, but
Okay.
you can have a look on this also. This is also uh, candidate for the candidate instruction. Okay, this is the scan of the patient. Okay,
Okay, doctor.
okay, Karoui. We will start
Uh,
now 10 minutes.
okay.
Okay,
Hello,
start.
Hello, I am Dr. Khani, one of the doctor in the clinic. Can I confirm name and age, please?
Yes, my name is Jean Patron, and I am 18 years old.
Yeah. Oh, nice to meet you, Jane. Jane, as I understood, mm. So I understood, Jane, that you are here to discuss the result of your blood test, and you are an uncus of diabetes, and you are pregnant 34 week. Am I right, Jane?
Yes, you are right, doctor.
Uh, So, is there anything you want to add?
No, doctor, but I am in hurry, please. You can finish your question so quickly because I am in a hurry. I am not free.
Oh, okay, Jane, I will try as much as I can. So, Jane, before we are going to discuss the results, I need to ask you some question to be more informative. Is that okay with you?
Okay.
Okay, Jane, can you tell me a little bit about your pregnancy?
Yes, this is my first pregnancy. It really in start it wasn't planned really, but okay, it is welcomed and everything is well. I follow my community, my midwife, my friend Sarah, and she follow me in this pregnancy, and I did my home reading of my blood sugar, and everything is okay.
Oh, Jane, I can see you are good in following your diabetes. And as far as your diabetes, can you tell me a little bit more about that also?
Yes, I have this diabetes since many years. I didn't remember how many years, but everything is okay, and I follow my doctor. He tell me that everything is okay, prescribe for me insulin, and I used to take this insulin, and everything is okay.
Oh, how much insulin are you taking?
Yes, I take 8 unit 3 times per day, and one type called Mixtard. I take it once daily, about 10 unit.
And when you are putting your insulin,
I
yeah,
put it in my refrigerator.
yes. And what about your glucometer? Is it working good?
Yes.
Mm. And as you tell me, your midwife is called Sarah. She is fine with you. What about in pregnancy with diabetes? We usually have joint meeting with the physician and the midwife. So when was your last meeting with the team?
Sorry, when was?
Your last meeting with the team of
Yes,
the medical team that take care of you.
yes. It was since 4 weeks, and I have another appointment in 2 weeks.
Yes. And are you student or are you working?
Yes, I am in college now.
Oh, that's very nice. And what about the environment in the college?
Everything is okay.
And with whom you are living in?
I live with my parents.
And are they supportive?
Sorry?
Are they supportive?
Yes, my parents love me very much, and they will support my baby even after delivery.
Oh, oh, that's very nice, Jane. Jane, what do you feel that you need help, or do you feel that you are hopeless, or low mood in the last 2 months, or you feel that you are anxious and
No,
you
no,
cannot
no,
focus?
no at
No.
all. No.
That's very nice. So, Dean, just one question. Do you have any other medical disease apart from diabetes or taking,
No,
you have any medical disease? Are you taking any other treatment apart from insulin?
no.
Okay, thank you, James, for sharing this information with me, and I want to examine you the process of that. I want to see how how far is your pregnancy, and I want to take your pulse blood pressure, and also I will tell the nurse to measure your test for your blood sugar. Is that okay with you, with the presence of chaperone?
Okay, okay, doctor. No problem.
Okay, thank you. Then I want to discuss the results. I want to discuss, the results of your test. Do you know, Jane, as you told me, that your blood sugar are okay and you are following up. But the problem with that, our blood test that we are did it for you, and we repeated that twice. It doesn't match with what you are telling me. So, what do you think? Maybe there is a mistake somewhere.
I don't know, doctor. It may be an error for your in your lab. I don't know.
Yes, Jane, but we did it twice, and also one of the tests we call it hemoglobin A1C. Do you know about? Did you hear about that before? You know that test, didn't you?
Excuse me. What is the question again?
Yeah. Did you hear about a test called hemoglobin A1C, which reflects the blood sugar level in your blood for the last 3 months? Did you know about that before?
Yes, I know that one. They did it for me in the start of my pregnancy. They said that they see the control of my blood sugar. I know.
Yes, yes, Jane, very good. This test is most likely we depend on to see the control of your blood sugar. You might be right that for the last few days you are taking your blood sugar and it's normal, but for the last 3 months it seemed for me that it is not for a good control. Okay, Jane, I'm coming to this again. I want to explain the scan for your baby. I want to assure you the baby is okay now. But if the blood sugar is stay like this and more than the accepted level for us should be like the hemoglobin A1C should be like 6. It is now 9. This means that the more sugar will go to your baby. I forget to ask you, did you name the baby? Jane?
Excuse me. Can you
Did you?
make your voice clearer? Yeah.
Okay. Did you name your baby Jane?
Yes. My baby Tom.
Tom. So in this case, if your blood sugar remain like this in higher level, mean more sugar will go to Tom, and Tom will secrete more insulin. So and this insulin make Tom bigger and bigger. And if Tom get bigger, this may endanger Tom's life in your womb. Did you know that, Jane?
No, no. First time to hear that.
Yes, I want to tell you that because if he get bigger, your delivery also may be more difficult. You may need more intervention, and also it may cause more trauma to you. The delivery may be difficult. The toe may stuck. The head of toe may get out, but the shoulder may stuck. We call the shoulder dystocia, and this also may cause a fracture of the bone. Also, you may need emergency cesarean section. Because of that, Jane, we can prevent all these by good control of your blood sugar. So, can you help me in that, Jane?
Yes, yes, doctor. Really, I did it only for my wife. I used to do only the home reading without checking my blood sugar. Only write the result without doing it for my wife to be happy, because I don't have time. I don't have time to do blood test 4 or 5 times per day.
Yes, you are right, Jane. I can see that you are busy and you are a student, and it look like difficult for you. I can appreciate that situation, but we want here to that you be safe for your safety and for safety of Tom. So in this case, I can also arrange a social worker to help you, or I'll tell the midwife even to come to home to help you in doing these tests. Is that okay with you, Jane?
Okay.
Jane, also I want to tell you, we need to admit you today, and you can call your parent about this. So do you have any objection for that?
Okay, time finish, but you can continue.
Thank you.
Okay.
So we need to admit you to do for you more blood tests, and we need to inform your physician so as to be sure about the dose of the insulin that you are taking. And I will call the nurse again to teach you how to do these tests more precisely. Is that okay with you, Jane, to be admitted today?
Okay, doctor, as you see.
Okay, thank you, Jim, for your cooperation. And also, I want to assure you, if you stay with good control, we can have a normal vaginal delivery, and we will take care of you, and we will have to deliver in hospital, and everything is going well. You can deliver normally without any complication. We will take care of the baby, and after delivery, I want to just advise you about having a good contraception, as you told me that this was unplanned pregnancy, especially in case with your diabetes. Okay, Jane?
Okay.
Okay. And Jane, if you want, I give you a name of support group to share your experience with the other patients that are in your situation, and give you information leaflet to read about it and to be more oriented about the situation. And if in any case you need any help, you are here, and I will instruct the midwife and the nurse to take care of you. Okay, Jane?
Okay.
Okay, Jane, do you have any question or anything you want me to repeat it for you?
No, thank you.
Okay, thank you, Jim, for your time. And now I will call the nurse to finish the requirement for your admission. Thank you, Jane.
Thank you very much. Well done. Well done, Dr. Karwin. You did it very well. You even don't put any blame on the patient, and you negotiate the patient very well, and you come about the hidden agenda that the patient didn't check her blood sugar at all at home, and only she did it for her midwife to make her happy. So this is one of the most difficult scenarios or session you may face, because dealing with a teenager patient will be very difficult and different from any other woman. She may be a stroppy girl and not concentrating with you at all, so it may waste your time during the session. So you have to be sometimes strict with her, but without losing the session. The problem is the history taking. You took many time or many minutes, more than 5 minutes in taking the history, and this is waste your time. So in the exam, please try to take relevant history and be more faster. And as we said, it will be by practice. Practice every day. Every day, a practice will make you very fast in the history. So the history, it is the trap that we all fall in it. So please make 3 to 4 minutes only in taking the history. You greet the patient, introduce yourself well, and confirm the identity and the purpose of the meeting. And you take all the history obstetric history, the gynecological history, the psychological history, all you ask about, and you explain the result very well. This patient may not open for you from the first time. She may not tell you the truth from the first time. So you have to assure her about her confidentiality and about that there is no one come to know anything about our discussion today. Our discussion today is very confidential, and she may open for you after that. And you did it really in a good way. It was impressing for me. Coming to the model of answer for this scenario. First, take care of counseling of teenager girl. It will be totally different for any other woman. You greet and introduce yourself and confirm the identity of the patient very well. And take care when you introduce yourself and greet the teenager. Also, it will be different from the first moment. It will be different when how you will greet this young girl, how you will introduce yourself to this young girl, how to make a friendly relationship with this young girl from the first start. How do you do this morning? Do you come to the hospital alone? I can see you. I can see you alone today. Do you come to the hospital alone? She will say yes. Okay, understand that you are here today because, and you will say your agenda, because it's the first time for me to see you today. I want to ask you some question to know more about you. Is it okay? She will say yes. Okay, then you will go through her present illness, ask about the diabetes as you did. You did it very well and you didn't forget any point. When was last consultation? Are you taking your insulin regular time? Any recent recommendation? I think you forget to ask about the kidney doctor and the eye doctor. It will be safety point because any patient with diabetes, especially the pre-existing diabetes, you have to mention the kidney doctor and the eye doctor. How do you feel right now? Because this patient is hyperglycemic right now. Her blood sugar is high and hemoglobin A1C is high. You have to ask about this. Okay. Coming to the obstetric history, could you tell me more about this pregnancy? And you ask in detail, and it was good. Any medical history, surgical history, allergies, smoking, social history? You ask about I think you forget to ask about her partner. I don't know whether you ask about her partner or no. This patient is living with her parent because she is still in the college, and she will tell you that her partner is supportive also, but he live with his parent also. Okay, so you will ask her who will support the baby after the labor. She will say my parent will support my baby because I have no time. Okay, psychological history and family history. Do you want to add anything? Thank you for sharing this information with me. Then examination will examine the patient, as you said, for the vital sign and to assess the growth of the baby. Okay, coming to the result of the test, let me confirm your name and the date of birth, please. Okay, she will say, okay, I am Jean Patron and I am like this. Okay, the scan show that your baby in a good health and your baby head is first. This means cephalic in lay language. The baby head is first. And the growth was the normal range, and also the water around your baby is a normal range. But the blood test that you did shows that you have a high blood sugar and hemoglobin A1 test is high. The hemoglobin A1 test, A1C test, it is a blood test to show the blood sugar control in the last 3 months. So, Jan, what do you think it may be the cause? You did well. You did well in asking that. You ask her, what do you think about that? Why? Okay, you didn't you didn't was judgmental in saying you are doing it wrong or you didn't take your blood sugar at home. No, you ask her first open question. Ask her open question. What do you think it may be the cause? She will say, I don't know. It may be error of your device. You said, yes, it may be an error for the lab and we will check for that. But Jan, I wanted to tell you that our discussion today is very confidential and no one come to know anything about it unless you want. Do you want to tell me something, Jan? She will say no. She will not open from the first time. Okay, you can come in another way. You have to you have to make a way for yourself. This patient not will open for you from the first time. So search about another way. Okay, Jan. I have many diabetic women following me in my clinic, and most of them find the monitoring of the blood sugar more than 5 times per day is tiring and stressful. Are you one of them? She may open here. Yes, yes, doctor. I do it only for my midwife to be happy, but I have no time to test my blood sugar. Yes, I can see that how busy you are. Here you can take your breath. The patient open now for you, so the scenario will go in a systematic way. But Jan, if you give me time to explain for you, and you explain the effect of the diabetes on the pregnancy and the effect of the pregnancy on diabetes very well, you may draw, and as I said, draw in every station. Draw will high your mark. Most of the diabetic women will have healthy pregnancy and healthy baby. However, some women may have a high blood sugar. Who have high blood sugar may have complication as the blood sugar will pass to your baby, and the baby may produce a large amount of the hormone called insulin, which build up the baby organ, and the baby will become larger than expected. And this will lead to birth injury, and the baby shoulder may stuck behind the pubic bone. This is the shoulder stock here after the delivery of the head, and this may cause injury of the nerves and the bone of the baby, injury of her muscle around the back passage, third and fourth degree pineal tear, and the bleeding after delivery, postpartum hemorrhage. Also, the baby may have a low blood sugar after delivery. So, Jan, I want to admit you in the hospital, and this to control your blood sugar, and you may need further tests. What do you think, Jan? She will say, okay, doctor, okay, as you see, okay, Jan, your safety and your baby safety is our priority. Then you will complete your cycle. Don't forget to complete the cycle: antenatal, intrapartum, and postpartum. Regarding the antenatal, your care will be under a group of doctor, multidisciplinary team. All the maternal medicine module, multidisciplinary team, which include obstetrician and the diabetes specialist and the specialist nurse. You will also see seen by the dietitian doctor, which learn you how to eat a healthy diet and do exercise. Also, the baby doctor will come to talk with you about the outlook of your baby. The eye doctor will examine your eye, and you will be offered a blood test to check your kidney safety point, eye and the kidney safety point, and also can be considered as applied knowledge. You will be offered the regular monitoring of your blood sugar during your admission, and you will be given insulin as decided by your specialist. Also, we will monitor your baby. When we will be sure that you are fine, and it's safe to you how to monitor your blood sugar. And you said that at home and your concentrate, very important point to warn her about the warning sign of hypoglycemia. But Jan, it is very important if you feel headache, sweating, irritable, hunger pain, to have a juice containing a fast-acting glucose, as this may be sign of decreased blood sugar in your blood. This is a hypoglycemia. This is mentioned by this way in the patient information leaflet of the diabetes in pregnancy. So you have to warn the patient about the signs of hypoglycemia. It will be considered a high point of safety for the patient. Regarding your delivery, it is most of the patient or most of the women with diabetes will have their baby around 38 weeks. And this will be by induced hair labor off. This is the induction of labor. Unless your baby weight is more than 4.5, you will advise it to have your baby by cesarean section. This is the recommendation of the NICE guideline. This will be in a consultant-led unit, and you will be offered the pain relief, monitor your baby. As I said before, fix this 3 point: consultant-led point, pain relief option, CTG. Also, we will monitor your blood sugar, and you will continue to have your insulin. After delivery, postpartum, baby doctor, breastfeeding, and contraception. Your baby will be checked by the doctor. baby doctor, and you allow to breastfeed your baby as soon as possible within 30 minutes and every 2 hours, and this to avoid your baby to have low blood sugar. And we will monitor the blood sugar of your baby within 2 to 4 hours, and we will decrease your insulin dose. This is a safety point. Most of you will forget this point. After delivery, will decrease the dose of the insulin again, and you will see by your specialist before you go home. Am I clear so far? Any other question? Okay, I will give you now patient information leaflet and the contact number in case if you have any query. Okay, thank you. This will be the model of answer for this case scenario. Any
Sir,
question?
please. Yes, sir. Can I ask you?
Okay, Dr. Ansar.
Is it important to admit the patient to hospital? Correct? Is it my job as an ST5, or I will refer her to the diabetes?
I'm sorry, I don't hear you. Can you make your voice clear?
Okay, sir. Is that clear?
Yes. Dr. Fernandez, can you mute yourself for a while, please? Okay, you can talk now, Dr. Ansar.
Is it crucial, sir, to admit this patient here into hospital to correct her blood sugar, or is this my job as an ST5, or I should refer her to the diabetes joint clinic to control her?
No.
Specifically, she has an appointment after 2 weeks.
Yes, but now her blood sugar is high and her hemoglobin A1C is high. So from my opinion, it will be safe point to admit the patient now in the hospital. And as you see, this is a teenager girl. If you allow her to go home, she may not come to after 2 weeks for the joint clinic. And so now you put the patient at risk. So the patient now with you, you can offer her admission. If she agree, okay, you will now take your safety mark, and the examiner will mark this point. So offer admission for the patient. You can also involve your consultant. I will involve my consultant if you are not sure about the admission. But as you see, this patient is a teenager and it is careless patient. She will not come in the joint clinic. And even in your daily life or daily work, if you have patient with fasting blood sugar is high and hemoglobin A1C is high, you will admit her to correct her blood sugar. What do you think?
Sir, I think as an ST5, this is not actually my job to control her blood pressure. I mean, specialists have to do so because it will be a grading scale. I will trial and error. I will increase the dose, or even I use another type of insulin, maybe increasing the nido because the fasting is high, and that's it. This is the job description of ST5.
Yes, I totally understand you, Dr. Intisar. I said you can admit the patient and her care will be under group of doctor. I didn't say that. I didn't say that. Dr. Singh, can you mute yourself, please, Dr. Singh? I don't say that you will monitor her blood sugar. The diabetes specialist will monitor her blood sugar, but you will admit and you will call the medical team and the specialist doctor in your ward to control her blood sugar.
But the diabetes joint clinic, because actually we are not aware of the system here in
Dr. Singh, can you mute yourself, please, Dr. Singh? Dr. Singh. Hello, Dr. Singh. Dr. Singh.
கருப்பு தான் பெல் கட்டுறது பெரிய ஆக்கள் சின்ன ஆக்கள் மெட்டாக்கள்.
Okay, Dr. Ansar, we can complete
Okay,
our.
sir, I'm sorry for that, sir. I'm sorry. Okay,
No,
we
you
can.
are welcome. You are welcome at all. You are welcome. So, from your opinion, it will be better if the patient refer to the joint clinic, and
Yeah,
in the joint
immediately.
clinic.
I will refer her immediately, not waiting on after 2 weeks. I will join her immediately and taking the opinion, and we'll take care of her. Actually, this is what I thought because I didn't know the system in England. How they do. So,
Sorry, Dr. Ali, but the joint clinic is already in the hospital. You can just consult the physician to come. No need to go to another place.
இப்படித்தானே அதான் பெல்ட் இருக்கப்பா.
I see that Dr. Karwin says some point about the joint clinic, but I didn't hear her.
Yes, I think the joint clinic, when they say the joint clinic, it is just in the hospital. The patient should be admitted. And they contact the physician and to come. The team, the multidisciplinary team that we are always talking about, they are already in the hospital. They are not far away.
Dr. Parveen, the joint clinic in the same hospital?
Yeah, joint clinic. Yes, joint clinic should be in the hospital. It is not far away. Any multidisciplinary team and any joint clinic in UK, it is in the hospital. It is not that we are the overseas thought that it is that another place or a difficult appointment. No, the patient should be admitted, as I told them, and as I told the patient, you should be admitted and
in collaboration with the joint clinic. Actually, we'll control.
Yes, it should be in the hospital. There is no other place.
Okay, thank you, Dr.
Okay.
Thank you, Dr.
Welcome, Dr. Ansar. Welcome.
Dr.
Thank you.
Thank you.
Yes.
Thank you, Dr. Ali. It was very informative. Thank you very much.
Thank you. Thank you very much.
In this case, do we need to tell the patient about risks of a sudden intrauterine fetal death? So that's why we are admitting her, because nobody mentioned this sudden intrauterine fetal death risk.
I think it will be. I think it will be intruding for. Yes, I hear you. I hear your question. I hear your question. But I think it will be intruding if you said that there is a risk for your baby, it maybe die inside the womb. Even with the controlled blood sugar, the baby may die. So this is not the point. The point is that, as Dr. Karwin said, your baby may be bigger, and it will lead to birth injury like shoulder tears in the muscle, and the postpartum hemorrhage, cesarean section, instrumental delivery. Like, okay. Another question?
Hello.
Hello.
Dr. Lee, this patient is also at the risk of preeclampsia. So we will also ask about the low dose aspirin is she taking, and this is type 1 diabetes.
I understand.
And she is also at high risk of preeclampsia. So I would like to ask whether she is taking low dose and proteinuria.
Yes, I understand your question, because diabetes, it is one of the major risk factor of preeclampsia. So this patient have to take aspirin from 12 weeks. But if the patient didn't take aspirin, what we will do?
Yes, I will just ask in the question in antenatal history whether she is taking from the 12 days and just to show.
Okay, you can ask a point. Actually, I write in my notes that this patient is at risk because she is diabetic. Because she is 34 weeks right now. So
while taking the history of present pregnancy while
Yes.
taking the history
Yes, you can mention
of
that.
present pregnancy. I will
Yes.
ask what amount of the folic acid she has taken, her ultrasound normally scans, particularly because there is this and
Yes.
preeclampsia.
Yes, you can mention. You can mention also this point. No. Okay. Thank you for all of you today. Inshallah, we will continue another session. We'll arrange our meeting in our group. Okay. Thank you. Thank you for all of you.
Thank you, Dr. Ali. Thank you.
Thank you. Thank you very much.
Thank you, Ali.
Dr. Ali, do you take the sessions
Thank you.
every Wednesday at the same time?
What?
Do you take these sessions every Wednesday at the same time?
We will arrange actually according to our duty and our my rota. So I will send in the group, inshallah, the next session, inshallah.
Okay, and is it possible for us to get the recording? Because sometimes we don't know what time it starts and we miss the initial part.
Okay, I will send. I will send.
Okay, thank you. And because especially with this noise and with this disturbance, it's really very hard to listen to the lectures. So better we can listen to the recording.
Okay, thank you. You are welcome.
Okay, thank you so much.